good evening, good evening, and welcome to this wonderful production here on blackdoctor.org. I am Ellis Dean, the Director of Digital Programming at Black Doctor. And I was thinking before we got on this show, I was thinking I come on here every time I do a program and I say, I'm Ellis Dean, the Director of Digital Programming at blackdoctor.org. And I'm like, some of you might be asking, well, what does that mean? What does it mean to be the Director of Digital Programming? What it means is we try to present programming that will give you the best, most up-to-date, most culturally competent health and wellness information that is available to us. Because we want you to be informed. As new information comes out, we come right to you. However, also part of my job is to tell you about conditions that you might not know about that you need to know about. So that's also part of my job. So I can tell you about diabetes and hypertension and all this stuff that we pretty much got a good understanding about. But then there's some conditions that you may have never heard of or that you might not know that much about. And we have to present that to you too because of how it impacts Black people. And that's what we're going to be talking about tonight. This is part one of our series called Blood Brothers, and we'll explain to you why we're calling it Blood Brothers. And this is about multiple myeloma. Now, we've talked about multiple myeloma a couple of times with our partners at LLS and other times to Blood Cancer Awareness Month. But we're going to do a 6-part series really breaking down what multiple myeloma is and, more importantly, what it means for you and your family. So when we said we're going to do a series on multiple myeloma, who can we get to do this series for us? And we went to the top. We went to the best. We like to bring you the best of the experts. And we have none other than Dr. Craig Cole with us this evening. He is an associate professor, he's a hematologist, and he works at Michigan State. Do I say the Michigan State? I don't know if I say the. He'll help me understand if I have to say the or at Michigan State University. And he is a great, great friend and partner for blackdoctor.org. So I know you didn't come on here me talk about how great he is. Let him show you a couple of things I need for you to do. I see Gerard's already checked in. Number one, let us know where you're watching from. Rep your city, rep your state, rep wherever you're watching us from all over the world. We'd like to know. So please drop that in the comment section. Number two, if you know somebody that needs this information, say, hey, I just learned about this. Have you heard about this? Please tag them or share this on your page because we like to get this information out to as many people as possible. And then number three, if you have any questions throughout tonight's broadcast, please drop those in the comments and we'll get them asked and answered because this program is all about you getting you the facts that you need to keep yourself and your family healthy. So I'm going to shut up and I'm going to bring in the man, as they say in the song, the man with the plan and the man demands you to come in. Dr. Craig Cole, how you doing, sir?
I'm good, Ellis. How are you? Thank you for the kind word. Thank you for the kind words.
I think that's probably the first time you've ever been introduced.
I prefer that, and it's just Michigan State. I went to the Ohio State,
okay,
but it's just Michigan State. Okay, you need to win a couple more football games to be called the Michigan State.
Well, I have just as a side note, I have a friend here in Atlanta. His son is a tight end there on the Michigan State football team. He was a freshman last year, so and he's projected to be good this year. So we'll see. Jack Nickel is his name.
Oh yeah.
So he's the child of a friend of mine, and his son, his little brother Luke, has also been offered at. He's a quarterback. Luke is a quarterback. At Michigan State. So we'll see if he chooses there. He's been offered everywhere. He's really good.
He should come to Michigan State.
Let's see if he'll come play with his big brother. But we're not here to talk about Michigan State. We're here to talk about multiple myeloma. And you have a wonderful presentation that you've put together to kind of give the one-on-one, just to break down as part one of our series, just what is multiple myeloma and what does it mean for Black Americans. So I'm going to pull this up and hand it off to you.
Very good. Again, thank you. My specialty in hematology is multiple myeloma, and it is a real passion for me. And it's really important, I think, for African Americans and really people of African descent to know about this disease. And I'll show you why in just a second. I think, what we'll start with is we'll talk about what are the blood cancers to begin with, what they are and what they aren't. About multiple myeloma, specifically the signs and symptoms, some fast facts about myeloma. Then we'll talk about the lab tests, because how we diagnose myeloma is with lab tests. You diagnose breast cancer with mammograms. You diagnose lung cancer with CT scans and chest x-rays. Myeloma is diagnosed and screened with lab tests. Then we'll talk about really the incredible treatments that we have for myeloma these days. And then we'll talk again about what to do if you think you have myeloma. So, one question is, what is myeloma? Well, yeah, I can tell you what it isn't. Is it bone cancer? It's not a bone cancer. A bone cancer is called sarcoma. It's very, very rare, happens to kids. And it's when cancer is in the bone, the hard part of the bone itself. Our blood cancers, cancer that's gone to the bones, because I hear that frequently. And cancer that's gone to the bones is called metastatic cancer to the bone. And so, like on the picture, breast cancer, colon cancer can go to other places, including the bone. And those are solid tumors that have gone to these places. Is blood, our blood cancers of the blood cells produced inside the marrow? And the answer to that is yes. So the blood cancers all arise from the marrow. And so what are these? Well, if you look inside the bone, there is the bone marrow. And the bone marrow, really that spongy stuff, is really a lot of different cells that are in there. Very, very heterogeneous population of cells. One group of cells are those cells at the top, the stem cells. And those make the red blood cells, white blood cells, and platelets. There are also these smaller cells called lymphocytes, so lymph gland cells. And they are born in the bone marrow. They go to the lymph glands that you can find in your neck and in your armpits. And they help defend against bacteria and infections that occur locally. And the permanent residents of the bone marrow are the plasma cells. And unlike the lymphocytes, which travel to infections, the plasma cells stay in the bone marrow and they fire antibody proteins towards infections. And so if the lymphocytes are the infantry, the artillery are the plasma cells, and they reside inside the bone marrow. But any of those cells can become cancerous. When they get mutated, those stem cells become leukemia. And it causes low red blood counts, low white counts, and low platelet counts. So a cancer of the bone marrow stem cell are leukemias. Okay. A cancer of the lymphocytes is called lymphoma. And those cells will grow out of control in the bone marrow, and then they will move to the lymph glands just like they would normally do. And then they cause the lymph glands to really expand and become larger and sometimes painful. But the myeloma cells, the plasma cells, when they become malignant and they mutate, they actually stay in the bone marrow compartment, but they'll produce lots of antibodies. And so these antibodies, unlike normal plasma cell antibodies, can't fight infection. In fact, what they do is actually suppress the immune system and drown out the normal immune system, which leaves people open to infections. And those antibody proteins, we'll talk about this in a bit, they have what we call a heavy chain, which are named IgG, IgA, and IgM, and light chain, which are called kappa and lambda. And we'll get back to that, why I mentioned the names of those proteins, because that's really how we diagnose myeloma, is that we diagnose leukemia with the bone marrow, we diagnose lymphoma, taking out one of those lymph nodes, and we diagnose multiple myeloma. First, we screen for it by doing a blood test looking for those antibody proteins produced by those malignant plasma cells.
I say, Doc, that's the first time I ever understood what leukemia was. So
good.
So thank you for that. I just knew it existed, and I knew we worked with LLS before, but I had no idea. I knew it was some sort of cancer, blood cancer, but I had no idea what the distinction was. So thank you for that distinction between leukemia, lymphoma, and myeloma. Thank you.
Perfect. No, thanks. So myeloma, because it's in the bone marrow, crowds out the normal bone marrow and can cause low blood counts. And low blood counts can cause weakness and fatigue. And we have mentioned how those plasma cells, that the malignant ones will drown out the normal immune system, causing infection. Those proteins that are produced by those malignant plasma cells can also get caught in the kidney. When they get caught in the kidney, then it can cause kidney failure, because the kidneys are filters.
Mm-hmm.
And if I put too much coffee in the coffee filter, nothing can get through. And then the coffee maker fails. My wife would kill me if I did that. But in the same way, when the myeloma cells are producing other protein, get caught in the kidney can't filter anything, which causes kidney failure, which causes weakness and fatigue. Those myeloma cells, they live inside the bone marrow, but when they run out of room in the bone marrow, they'll actually move to the bones, into the bone marrow of your arm, of your ribs, of your breastbone, of your back. And when it goes there, it weakens the bones, and which can cause bone fractures. And that actually happens in a lot of myeloma patients, is bone fractures, which can cause bone pain. And because it causes bone damage, it can lead to high blood calcium levels, because we store all the calcium, and we store our body calcium inside the bones. So when those myeloma cells are tearing up the bones, causing pain, it can also cause high calcium levels, which can cause a lack of appetite, confusion, and weight loss. And you can see that a lot of the weakness, fatigue, infection, bone pain, loss of appetite, weight loss are very common symptoms of a lot of different things.
Mm-hmm.
But the one thing that we'll talk about is it is easy to rule out this as a cause of those things by doing just a couple blood tests. And
Okay.
about 10 to 20% of myeloma patients won't have any symptoms at all. They'll have some blood tests done for insurance purposes, or they'll have blood tests done by their doctors for other reasons. They'll see a high protein level, and then that will have them suspect myeloma, even in someone who doesn't have any symptoms.
So quick question, because I know we do a program called Kidney Talks here, and we talk about chronic kidney disease and transplants and things of that nature. And one of the symptoms of chronic kidney disease to show that your kidneys are failing is a lot of protein in your urine.
Mm-hmm.
So could it be like, not saying misdiagnosed, but like if they could stop it just at trying to repair your kidneys, and it could be a sign of myeloma?
Yep. And so when the myeloma protein gets caught in the kidney, it actually makes the kidney cells leak protein.
Mm.
And you can catch that protein in the urine. So you're right. Diabetes also causes, things that cause kidney damage can cause proteinuria, and cause protein in the urine. This is one of those things that can cause that.
Okay.
And I just saw a patient today who had diabetes, and their doctor was saying, yep, you have, proteinuria because of your diabetes. They went to a kidney doctor, and they did the blood tests and found that she actually had multiple myeloma.
Wow.
And we were able to treat her and put her into remission, pretty well.
Good.
So we use a mnemonic to remind us exactly what are the signs and clinical characteristics of myeloma, which is called CRAB. The C meaning the high calcium levels, the R meaning renal, but really renal is just a medical term for kidney function. Mm-hmm. A meaning anemia or low red blood count, and B meaning bone disease, or those holes in the bones that can cause fractures. Myeloma is the second most common blood cancer behind lymphoma overall for in the United States. We diagnose about 35,000 cases this year. And I'll show you, the incredible thing is that there are more and more people living with myeloma in the United States, in large part because people have stopped dying of the disease. And I'll show you a graphic on that in a second. It's a disease of older people. As I get older, that term becomes less and less important. But it's a disease of adults, that you never see myeloma in kids. Okay. I think one striking thing that you can see is that the incidence in blacks are much, much higher than it is as for whites. And we'll kind of dive down into that right now.
Which is why I
that
said in my opening, that's why we're doing
Mhm.
this programming, because myeloma, when we're talking about those three blood cancers, myeloma one, the incident rate in African Americans is really, really high. And so we have to, or people
twice,
of African descent.
yes, twice as high. And it's more common in men than in women, but it's actually twice as high in people of African descent. So that's just not the United States, but that's around the world.
Right.
So, there were
That's the title.
reports.
That's the title, Blood Brothers, right? That's
Yes,
what we call it.
exactly. I was happy to see that title because that's absolutely the truth. Is that men and Black people have people of African descent have a much higher rate, the highest rate in the world of this disease.
Right.
People of Asian descent have the lowest risk. Hispanics and whites are kind of in the middle. And you can see on that graph that blacks and green outpace all other races. And then you look at, as we get older, a black individual or age 85 has the incidence is about 75 per 100,000. So it's very common in our oldest group of Black individuals, and again higher in men, which again, that's why your title, I think, is very timely, because that is who is most affected by this disease. We don't know, I'll tell you, we don't know why that is. We have looked for decades to try and figure out why is the incidence higher in people of African descent than all other races. It's not because of alcohol. It's not because of job, of occupation. It's not. It used to be more common in farmers back in the 70s and 60s because of pesticides. Those pesticides have been removed, and we still see the incidence of myeloma climbing. And so we've looked for decades to try and figure out why is this difference exists, and it is something I believe deep in our genome, deep in the differences. When everyone was coming out of Africa, tens of thousands of years ago, and the races began to be exposed to different infections that then change our immune systems to adapt to that, which may lead to a difference in incidence of cancer of the immune system, such as multiple myeloma.
Well, there's a question from one of you, and she's asking. First she said why, and then she's like, what role do you think stress plays in
That is an excellent question, and taking off my Dr. Cole hat, or like I said, putting it on the side.
Right.
Definitely, stress affects the immune system, and there's a lot of literature that is behind that. And in fact, I was at a conference that really talked about the microaggression of being Black in America as being one of, it was listed as, is that one of the things that are driving the incidence of this disease? And my personal belief is that amount of stress, which hangs a weight on the immune system, may be in part due. That is really hard to measure because our understanding of stress in the immune system is really in its infancy.
Right.
But my personal belief is that I believe that it is. And I think it's really tough to eliminate some of those stressors in our lives. And when you look at the incidence rate and the death rate of myeloma, you can see that the darker the state is, the higher the incidence and the higher the death rate. That in the in the southeast and in the Midwest, the incidence is higher. And again, we're really trying to get our arms around why that is. I think some of that is that we don't have enough awareness about this disease in those areas, which is why, again, I am just thrilled that you've asked me to talk about myeloma, because I think the more that we have awareness for it, the more that we can diagnose this disease early, the more lives that we can save in those sensitive populations.
So it could be also, this is kind of spitballing, there is a higher concentration of African Americans in the southeastern parts of the country, and so you're going to see higher incident rates and higher death rates just because of the
Absolutely.
population of African Americans. There are a few people that are just joining us, and there's a couple questions that says, could you just kind of revisit what is myeloma so we can kind of get people caught up as we're talking to?
Absolutely.
Yeah.
So myeloma, multiple myeloma, is a cancer of the immune system, and it is a cancer of the plasma cells that live inside our bone marrow. And those plasma cells normally help us fight infection. But just like any other cell in the body, those plasma cells can become malignant. And when they become malignant, they produce excessive amounts of protein in the blood, which is how we diagnose myeloma. Those proteins produced by myeloma can get caught in the kidney, causing kidney damage and protein in the urine. It can cause anemia, and it can cause high calcium levels, and it can cause the bones to become weak because those plasma cells leave the bone marrow and go to the bone, weakens the bone, which causes pain. And so it is a cancer of the immune system. And we know that it is twice as common in people of African descent and in African Americans compared to all other races. And why that incidence is so much higher, we don't know yet.
All right, Charles, we got you caught up. Sorry.
Okay. And again, when you look at, this is from the SEER database, which is a database that keeps track of cancer around the United States, that the incidence you can see is climbing for myeloma. Blacks are at the top bar, and the incidence again is climbing as compared to all other races, which is the lower bar. And even though you can't see it because I have the graphic, that the mortality is higher per 100,000 for blacks as compared to all other races. And this is one of the largest survival disparities seen in cancer in the United States. So myeloma, so we talked about those malignant cells and how they behave malignant and how they cause problems. Well, they start out being pretty benign and start out being pretty quiet. And that precursor condition is called MGUS, monoclonal gammopathy of uncertain significance. So what kind of name is that? Monoclonal is that protein, mono meaning one, clonal meaning source. So monoclonal protein, gammopathy means protein, pathy means abnormal. So monoclonal gammopathy is a single source protein from those plasma cells that's abnormal. And when people have, and MGUS is very, very common, about 3% of the population has it over age 50. And that's when people have low numbers of those mutated plasma cells in the marrow, low amounts of blood protein, and no symptoms. Very common and a very low risk of turning into myeloma. Over years and decades can go by, and then people can develop something called smoldering myeloma, when there's a bit more plasma cells in the marrow. So the normal number of plasma cells is 1%. If you have more than 10% of those bad plasma cells, then you have smoldering myeloma. But again, no symptoms, none of that crab that we talked about, the high calcium, kidney damage, anemia, bone disease. And eventually that could turn into true myeloma, which is when you have done a biopsy and you find those plasma cells in the bone marrow and you see that high protein level, and people either have one of those features that we talked about with the high calcium, kidney function, anemia, bone disease, or if they have lots of plasma cells in their marrow, more than 60%, or their light chains, the protein is real, those little fragments of protein are really high, or if they have more than one lesion, then they are at very high risk of having something bad happen. And in the multiple myeloma group, those are the folks that we treat with therapy. And I could kind of mention that MGUS, that precursor condition, which is so common. The reason that Black people have more myeloma is because they have more MGUS than other people. They have more of the precursor condition. And that precursor condition, again, you have no symptoms with that. There's no way that you can know you have MGUS other than doing the blood test. And MGUS is, again, 2 to 3 times more higher in people of African descent. And when African Americans are diagnosed with MGUS, they usually have very low protein levels, a higher rate of those fragments of protein that we'll talk about in a second. They actually would get diagnosed with MGUS about 10 years younger than all other races. And they have higher amounts, a higher incidence of the IgA and IgM protein, which is a specific type of protein made by those plasma cells. The good news is that although Black people have more MGUS than other races, the chances of it turning malignant is the same across the board. So even though we have more MGUS, the disease MGUS doesn't behave more aggressively in Black people. The other risk factors for myeloma besides MGUS, there isn't any convincing evidence that myeloma is inherited. However, MGUS, the precursor condition, is more hereditary. So people that if you have a brother with myeloma, your chances of having myeloma is pretty low, but your chance of having MGUS, the precursor condition, is higher. And we see that hereditary link, that kind of weak link between of myeloma being hereditary, more with Black people than other races. Again, we can't explain that racial difference by tobacco, alcohol, socioeconomic status. Obesity does increase the risk, and that's some of the research that we're doing is to figure out why obesity increases the risk. The fat cells secrete some chemicals which may be driving myeloma, so we're working on that. Exposure to ionizing radiation.
As a point, there are about 236 different conditions that are associated with obesity. And so therefore obesity, if you keep going up the food line, there's going to be some connection to obesity. So for people, the best way to stay healthy and remain healthy is to get out of that obese range as quickly as possible. Because
Absolutely. And ionizing radiation is a convincing risk factor. There's lots of ways that we now have avoidance of ionizing radiation. And it's usually ionizing radiation in low amounts over decades. So it's not, you didn't see myeloma with the atomic bomb being dropped. It's people being exposed to low amounts over long periods of time. And the same thing with chemical exposures, that it's chemical exposures, not there. Is there any one chemical that causes myeloma? No. But being exposed to chemicals over very long periods of time can increase your risk of myeloma. Myeloma is different in African Americans than in other racial groups. That again, in the same way that MGUS is diagnosed and seen about 10 years earlier in people of African descent, myeloma, by the same token, is seen about 4 to 5 years earlier than their white counterparts. One thing I hear all the time is that Black patients will go to their doctor and they'll have myeloma and they'll say, "Gosh, you're too young to have this disease." Mm-hmm. And part of being Black with this disease is that we present younger than other racial groups. The Black patients are more likely to present with the anemia, with high lactate dehydrogenase. We'll talk about that as a chemical that is released when the myeloma cells are being active. And one important thing, is that African Americans have different mutations that cause this disease than Caucasians. Specifically, you'll find frequently in patients, and Black patients have myeloma, that the 11th chromosome and the 14th chromosome will be stuck together. And the good thing about that is that doesn't increase the severity of the myeloma, but it is a target for a potent new drug for myeloma called venetoclax. And so we're really trying to get our arms around having African Americans and Black people involved in clinical trials with this drug, so that we can, because that is one target that a fortunate target, one of the most potent drugs for myeloma, in a mutation that commonly occurs in African Americans. The other good news is that African Americans are less likely than whites to have the really high risk, really severe mutations in myeloma involving the 17th chromosome. And there have been several studies, really over the decades, that have shown not only just recent data, but even older data that shows that under equal opportunity settings, the VA medical system, clinical trials, that African Americans have a as good, if not better, survival of myeloma, in part because we have that the myeloma that we have has better cytogenetics, less high risk cytogenetics, which and those high risk cytogenetics and mutations do have patients die earlier with this disease. And so, learning your labs, the CBC is a test that everybody, gets, where it looks at the red blood cells, white blood cells, and platelets. And again, anemia in those red blood cells is a sign of myeloma. The comprehensive panel is a chemistry panel that looks at the calcium, the kidney function via the creatinine, and looks at bone health with a test called alkaline dehydrogenase. And so those are two of the tests that help us look for myeloma. The beta 2 microglobulin and the LDH are used for staging. They give us an idea of how many cells there are and what their behavior is. But I put in red the main tests that are used to diagnose this disease. And again, is looking at that protein produced by those malignant plasma cells. The serum protein electrophoresis tells how much protein is being produced. The immunofixation tells us what type, one of those three types of protein that I had mentioned, IgG, IgA, or IgM, kappa or lambda, and then the free light chain test, which finds those fragments of protein that those mutated plasma cells can produce. I didn't highlight the urine tests because the urine tests are urine tests. They're pretty clunky, and we don't use it as much as screening as we do the big three: the serum protein electrophoresis, immunofixation, and serum free light chain assay. So this cartoon didn't turn out so well, but it's kind of described with the serum protein electrophoresis. But I think the next one really tells you something important, that the reason that the serum protein electrophoresis works is that all those plasma cells are identical. They produce identical weight protein, which can be detected on the serum protein electrophoresis. And the more plasma cells there are, the higher the protein level. And that's how we can detect the MGUS, we can detect myeloma, we can detect all those diseases by doing this serum protein electrophoresis test, which finds out if that protein is being produced by those malignant plasma cells. The one thing is that those plasma cells can be kind of tricky, and sometimes they produce fragments of fragments of protein in 17% of patients. And again, we used to use 24-hour urine proteins and spot Bence-Jones proteins in the urine to be able to detect it. But now we use the free light chain test, and really that has been revolutionary. That has allowed us to really screen and diagnose lots and lots of patients conveniently with a single blood test. So how does that test work? Well, me sitting here right now, I'm producing small amounts, about a milligram, maybe a milligram and a half of either kappa or lambda protein. That's what my normal plasma cells are doing in my body, producing low amounts of those proteins. And the ratio between the kappa and lambda are about even. And that's just my normal immune system doing its thing. However, if I have very high kappa or very high lambda, because I have, again, mutated plasma cells in my body, then you'll have one very high level, one normal level, and the ratio between those two will be abnormal. And that's what you're looking for. The good thing is that this is a blood test. It's just like any other blood test, small amount of blood. And it looks to see, are those plasma cells producing that heavy protein that we find with the SPEP, or is it producing those fragments? But you got to do those two tests, because 17% of patients with myeloma will only produce the little fragments of protein that we have to look for. And so again, the serum protein electrophoresis alone will pick up maybe it'll pick up about 90-80% of the myeloma, but you don't want to be that 10 to 20% that gets left behind. And you look at the very bottom, when you combine these three tests, the serum protein electrophoresis, looking for the heavy proteins, the free light chains, looking for those light proteins, and immunofixation, identifying the type of protein, 100% diagnosis rate for MGUS, and really 100% for amyloid, which is another plasma cell condition, and 99% to 100% with myeloma. So again, that three tests will pick up, the precursor condition and the cancer itself. To finish the diagnosis, then we used to do x-rays. We've been doing x-rays for myeloma for about 125 years. And it will pick up lytic lesions or holes in the bones in about 75% of patients. PET scans have revolutionized everything. I mean, that's like me putting on my glasses in the morning. That PET scan can see so much better and such a better test. And really it's become the standard of care to do a PET scan. It's just like a CT scan, but it hunts specifically for those myeloma cells in the bone and is about 85% more sensitive than the old skeletal surveys used to do. And then to get to the final part, we do a bone marrow biopsy where we take right from the low part of the back, from the hip bone, we take a teaspoon of that bone marrow and we analyze it and count those plasma cells. And again, if it's more than 10%, and you have those other symptoms, then you have multiple myeloma. The other thing that we do with those plasma cells is we look to see the mutation that caused the myeloma in the first place, which then helps us assign the risk. If it has those really bad mutations, it's high risk, high stage. If it's some of those good mutations like the 1114 that happens in Black patients, then it's not the high risk type. And again, it gives us lots of treatment options.
If you're just joining us, we are talking to Dr. Craig Cole. He is a hematologist and associate professor at Michigan State University, and he specializes in multiple myeloma. And as we learned earlier today, multiple myeloma is twice as likely, is twice as active in Black people of African descent. But we also, the promising thing is that if we catch it earlier, we have a better chance of survival. And so therefore, that's why we're trying to give you this information. So when you see that symptom kind of change put up, we talked about the different tests. It's a simple blood test. Get those three. They're pretty much 99% to 100% chance that they can determine whether or not you have multiple myeloma. So this is part one of our 6-part series on multiple myeloma. So we're going to break it all the way down. But today we're just doing multiple myeloma 101. We're just getting into it, what it is, what the symptoms are, treatments, the whole shebang bang, as we say. So yeah. Go ahead.
Well, how we know? Thanks. That's a very good. You said what I said in a half hour in just a few minutes. So thank you very much. Now, how do we treat myeloma? Is that we use science. The treatment, the main types of treatments that we use, are the immunomodulatory drugs, the proteasome inhibitors, and antibodies. But you see, chemo isn't on there. So we only use we use chemotherapy once in this disease course. Otherwise, we're using targeted drugs. And the novel therapies, all the new drugs that are coming out is really incredible. And I'll talk about that in a second. So the tools that we use to treat myeloma, again, are the immunomodulatory drugs. We used to use thalidomide, that old drug, from the 50s and 60s. But now we usually use Revlimid or lenalidomide, which is a pill. We use a proteasome inhibitors, usually Velcade or Kyprolis, and to treat myeloma. And we use a new antibody therapy called Darzalex or daratumumab, which gets the immune system to hunt down those myeloma cells and kill them. We still use steroids to treat myeloma, and occasionally, again, we'll use melphalan or chemotherapy, and I'll show you where we use that in a bit. So when we have patients with myeloma, the first question is can we give them one dose of high-dose chemotherapy. Are they a transplant candidate? We use transplants to treat myeloma, and a bone marrow transplant that we use for myeloma, you use yourself as a donor. So we give you an induction therapy for the myeloma, which gets rid of 90% to 100% of the disease, and to clean up the extra remaining part of the disease. After people have gotten their induction therapy, we give them 1 dose of chemotherapy. That dose is so high that we save the stem cells away, give the chemotherapy, and then give the stem cells back. And that allows us to give high doses of chemotherapy safely, where people, they're in the hospital for a couple weeks, but the chemotherapy is safe. And what I'd like to tell people doing a stem cell transplant is like a 1-2 punch, that the induction therapy is the right, and I don't know much about boxing, I'll be honest with you, but the right hook is the induction therapy, and the left hook is that chemotherapy from the transplant that knocks the disease out. Then we do a little bit of treatment after that, and then people are on maintenance therapy. If people aren't transplant candidates because they have a severe heart disease, severe lung disease, or if they are immobile, then we'll give them the same induction therapy and follow it up with maintenance therapy to follow. And again, there are lots of different induction therapies. I highlighted some of those. The good news is that the ones I highlighted in yellow have a 96 to 99% response rate. I mean, these drugs work incredibly well at treating myeloma. Again, that consolidation with stem cell transplant or continuing the induction therapy, and everyone gets some type of maintenance therapy. Now, once we knock the bad guy out, then we keep it down with maintenance therapy. We can't cure myeloma yet. So when it comes back, then we can really open up the playbook. And you see there are lots and lots of therapies that we can use for relapse myeloma.
So relapse in a future program. So we're going to talk about relapse.
In fact, here's a little graph that is kind of complicated, but when you start out, on the left-hand side with myeloma, you get your induction therapy, possible transplant, then you go into maintenance, and the disease is at a very low level. At some point, then hopefully, usually about 5-6 years later, the disease comes back, you get a second treatment, it goes into a remission, and then that cycle can go on, and hopefully there's years that pass by when patients, between their different therapies. And then what we call relapse refractory is when we treat and it doesn't get better. And that's when we use clinical trials. And the clinical trial drugs that we now use to treat myeloma, there was just a paper that came out a few months ago in June that showed that one of the newest combinations of drugs for myeloma for relapse refractory, people who are really sick with this disease, has a 95% response rate. That number was 30% 6 years ago. We've gone from refractory myeloma response rates being 30% a few years ago to 95%. And so do I think we're going to cure myeloma one of these days? I think we're going to cure myeloma one of these days. And so, my last slide, the new therapies that we use to treat myeloma, again, have a 98, 99% response rate. We've had 32 drugs approved by the FDA between 2015 and 2023. We have 2 more that are going to come out later in 2023, I hope. And really the survival, when patients ask me, well, how long do I have to live with this disease? I don't know anymore, because more new things are coming out, more effective therapies. When I first started doing this, response rate was 30%. Now it's 99%. And for a really bad disease, response rates are just a few months ago, 95%. And so I don't know how long people have to live, because the new therapies just keep coming out over and over again, which is fantastic. And again, back in 2004, there were only 54,000 people living with this disease. Now, in a couple of years, there'll be 160,000 people. The reason is because people are surviving this disease. And again, I am incredibly thankful to be able to share that good news with everyone. So again, the back mnemonic that I tell people, could I have myeloma, where you think back. B standing for back pain or bone pain. So think back. B being bone pain. If you have bone pain, ask for the myeloma testing labs. That SPEP test, that free light chain assay that we talked about, immunofixation, it tells you the type. If you're Black and have anemia, they test you for, gosh, how many times have I been tested for sickle cell? When I tell them I don't have any sickle cell in my family, they should be testing me for these blood tests, these 3 tests. If you're anemic, if you have new onset anemia, ask for the blood test for myeloma, just to make sure that that's not what it is. If your calcium level is high, and there's not a lot of things that cause high calcium in the blood, again, ask for the 3 tests. And if you have kidney damage or low kidney function, again, ask for those 3 tests. If you have protein in your urine, yes, there are a lot of things that can cause protein in the urine, but you can rule out this as a cause by just doing those 3 blood tests. And I think that's it.
Okay, I'm going to put that on the screen there. So we'll run through it again here. What the back is. So we're looking at bone or back pain. Okay, so we're looking for bone or back pain. I've heard stories from people from survivors of multiple myeloma that say they discovered it because they had a random bone break, and that's what spurred them to go down that line with regard to, hey, I didn't really hit my bone very hard. Nothing really happened. I was jogging, I was running, all of a sudden my ankle broke or something like that. And that could be the impetus that what Dr. Cole was talking about earlier, where your bones, so much stuff can get into the bones and they become brittle and they can fracture. So bone or back pain. Anemia, right? And we understand that there's a lot of things that can make us anemic, right? So understanding, but this is that symptom. This is a potential symptom. So as we start putting all these symptoms together, anemia, particularly, I think you said earlier that anemia is a prominent symptom in patients of African descent.
Yes, yeah. Anemia and the kidney function problems are more prominent in African American myeloma patients than in other races.
Absolutely. And then C, high calcium levels. As Doc said, unless you are just chain drinking milk or popping those calcium pills over and over again, there's not a reason to have really high calcium levels in your body, and so therefore that could be a marker or a sign for myeloma. And then finally, kidney, and this is the trickiest one because there's a number of things that can cause damage to our kidneys. And so our kidneys are very, very sensitive organs. As I'm learning, they're very, very sensitive organs. So they're sensitive to blood sugars. They're sensitive to hypertension. They are sensitive to proteins, high proteins in the bloodstream as gets produced by myeloma. So there's going to be a battery of tests. And so if you're having some situations where your creatinine level is high and they're saying, hey, there's 5 stages of renal failure. So if you start getting to stage 3 and 4 of renal failure, then you might want to ask for a larger battery of tests to make sure the origin of your renal failure is not myeloma.
And because the response rates are so high, I mean, these treatments, that we use for myeloma have, these days have 99% response rate. We can reverse all those things. The patients I've had that came in, sometimes on dialysis, that come in, with really bad kidney function, come in with bone pain, come in with bad anemia. Those things correct very well. And I would say within 4 to 6 months, the anemia goes away, the pain gets way better with it. But the trick is to really ask for the test, because Black people are, on average, it takes about 5 months to diagnose myeloma in a Black person as compared to 2.4 months in a white person. And some of that ownership is we got to get doctors to remember to think about that with Black patients. And of course, we need to advocate for ourselves and say, can you test me for this? And again, because a lot of these things are reversible if we can catch it early.
Absolutely. We had a great some great comments here from Marshall. He said his 80-plus-year-old grandmother had a diagnosis of MGUS, but it never progressed to the smoldering stage. So and then he also he'd really been studying, because he said he remembered now she did have idiopathic high calcium, some kidney proteins on the say, and anemia, which was treated by iron therapy. So absolutely, but that is Marshall. You are the indicative of the type of person we'd like to have after watching these series of programs, is to have a better understanding of myeloma, and to be able to really, what we want you to do is be able to differentiate, not on your own. Because I mean, doctors, you can work with your doctor, but you can ask that question if your doctor is saying, "Oh, I've noticed your kidney function, your creatinine levels are high," and say, "Doc, since it's a blood test, can we test for myeloma?" Right? And then have those three tests that Dr. Cole mentioned, and let's rule it out. It's best to rule it out versus going down a path of treatment that might be ineffective.
And it's good, to know. I always tell people, to know if that you have that precursor. If you know that you have MGUS, you are as safe as a bug in a rug, because knowing that someone has MGUS, they should never have any of those bad things happen. Because you'll see that protein that when people with MGUS, we check it once a year. If we see that protein going up, we just don't let people get sick. We use those medications, push it down, so people will never get those bad things happen to them.
And there you go. And so that's what we're trying to do. But you won't know if you have MGUS if you don't unless you test. And so this has just been fantastic. A fantastic presentation. This is first of 6. So stay tuned. We'll be back next month. And next month it's July. So let me hold off. September is Blood Cancer Awareness Month. And so we're going to do a special presentation about myeloma there. But just the last thing I will say, and I'll give you the final word, Dr. Cole, is Black families, we have to have those health conversations. Because we are going to lose, we're going to get stuck generational and generation if we do not have these conversations. Even if it's diabetes, hypertension, you need to know what's in your family medical history, cancers, things of that nature. You need to know what's in your family history, so you can have a better chance of being able to prevent, if not, or get ahead of any potential conditions that you could develop.
Yeah, I mean, today the treatments, I mean, across the spectrum of medicine have improved from the days I had hair to today. Things have gotten so much better, and prevention has gotten so much better. And so, we tackle these things early, we can prevent problems, and live very, not only long lives, but live very healthy lives and very fulfilling lives. And so we don't want to suffer. We want to just, as my mom used to say, is carry on.
One final question that just popped into my head, Dr. Cole. People with myeloma are immunocompromised, yes?
Yes.
And so I know there's still a variant of COVID out there around. What should they be doing if somebody has myeloma? What should they be doing to protect themselves from this new variant of COVID that's out there?
Yeah, definitely. It's a super good question, and definitely, build that armor of immunization around you. That to have people immunized that are around you, and to have you, immunized. And we learned that message, from back. Not back in the plague days, but back in the smallpox day, that when people were surrounded by immunized people, that they had lower incidences of infectious diseases. And you're right, having COVID with myeloma is a really tough ask, because the immune system doesn't work very well. but also, having a good relationship with your primary doctor to be able to prescribe, those some of those medications for COVID, like Paxlovid, early, so that you can suppress the disease and not get really sick from it.
Absolutely. Well, thank you again, Dr. Cole. We'll look forward to our next episode here of Bone Brothers. And so you learned
Yes.
tonight why we're calling it Bone Brothers. And so Dr. Cole is my honorary bone brother here on blackdoctor.org. Thank you again. Thank you all for joining us. Thank you for your comments, and we'll see you next time.
So thank